afternoon, everyone. Is my screen visible?
Yes.
Okay. Good afternoon, everyone. In today's CME by Gynae Forum, and the topic of the today is fetal echocardiography, what obstetrician must know for interpretation. This CME has been brought to us by Dr. Sharda Ma'am's initiative, and we have experts in this meeting. Dr. Deepika Deka Ma'am, Dr. Poonam Goyal joining us shortly, and speaker is none other than Dr. Krishna Gopal. I'll be just presenting a short CV. Everyone know Dr. Deepika Ma'am. Ma'am has been instrumental in developing the fetal medicine department.
I think you can stop it.
Sciences. And Ma'am is presently working at Cloud9 Hospital in Gurgaon.
Damage of the bladder, and which happens.
Dr. Poonam Goyal Ma'am, she is HOD of IVF Max Hospital, Delhi, and director of Panchsheel Hospital. Ma'am has been past president of IMA East Delhi and branch, and past member of PCPNDT advisory. Ma'am has many awards for credit. Welcome, Dr. Poonam Ma'am. We have with us Dr. Jyoti Agarwal Ma'am. Ma'am is a senior consultant and director of Life Care Center and Life Care IVF. Ma'am is presently advisor of Delhi Gynae Forum East. And Ma'am is a certified trainer for Delhi Gynae Forum in fertility and IVF, ultrasound and colposcopy and thermal ablation training. Ma'am has been awarded with many awards to her credit. Welcome, ma'am. We have with us Dr. Jyoti Malik, ma'am. I think she'll be joining us shortly. Ma'am is a senior consultant of obstetrician and ART specialist. She's presently secretary Delhi Gynae Forum, Outer Delhi. She's the director at JG Institute of Medical Sciences at Bahadurgarh, Haryana. Welcome, ma'am. And we have a speaker with us, Dr. Krishna Gopal. Everyone knows in this forum. He is a clinical fellowship from Singapore General Hospital in Singapore, Fetal Medicine Foundation certified, and is a national secretary of Society of Fetal Medicine India. Welcome, Dr. Krishna Gopal. I'll be just stop sharing and I hand over my mic to Dr. the chairpersons for the meeting.
Good evening to everybody. I think it is a very important topic because a lot of patients, fetuses could be having malformations of the heart. Of course, there are certain indications where you really have to do a detailed fetal echo, but obstetricians must know that at least they should be able to see the four-chamber view and the outflow tracts. So if we know how to do that much, 90% of the cardiac malformations will be detected. And the most important thing for obstetricians to see is that whether the heart is looking normal or not. Even just by looking at the size of the heart, by looking at which side it is, and then also trying to see the cross, we call it the Holy Cross. That itself is common sense enough for the obstetrician to say that something is not right with the heart. And then I should go and get an expert opinion from a cardiologist. So I think today's talk is going to be very, very useful. So I request Dr. Krishna Gopal to proceed. But of course, I think Dr. Sharda Jain should speak a few words first.
These women can be admitted and the delivery plan should be in place.
What I find is that we gynecologists were told by Dr. Khurana 2 years back that echocardiography is must. And I come to know from Dr. Gopal and Dr. Khurana again that in spite of you do a level 2 ultrasound to scan anomalies and even you do an echo, there is a good chance of 40% that you may not be able to detect heart diseases. So at times, people like me wonder, it is must, but at the same time, you require a lot of counseling to your patients that all malformations cannot be picked up. And this particular part should be definitely there that, they must know that all malformations cannot be predicted, and heart disease is one of the commonest. And I think, not many times we don't even know the interpretation, like cross sign as told by Dr. Deepika. I do not know what the cross sign, so I think I'm going to learn it with Dr. Gopal's presentation. So over to you, Dr. Gopal. I think, every gynecologist must know about it, that not only an anomaly scan, we have to get an echocardiography done and how to interpret it and counsel your patient, write down on the files that all malformations cannot be picked up. So they cannot blame the ultrasonologist and you who are the patient whom under care you are. So over to you, Doctor.
Thank you, ma'am. And good afternoon to all of you. So here is my presentation. And the first thing that we always think that what is the place of this kind of lecture? Why this kind of lecture is required in today's scenario? So this question will be first discussed. That what is the need of this kind of talk in today's scenario? Because there are experts who are gonna be taken care of all this mental malformation. So first, because of the impact of the congenital heart disease. This is nowadays the most common congenital defect, because you people have really treated neural tube defect very well, adding folate. So neural tube defect worldwide incidence is going down, and it is the congenital heart disease that is the number one. Number one is not in a good way. It is 6.5 times more common than that of the chromosomal anomalies. It is 4.5 times more common than the neural tube defect, and it attributed to 20% of neonatal death. So, why this lecture is particularly required? This lecture is required because the suspicion of diagnosis is done by the imaging specialist, ultrasound done either by the sonologist, radiologist, or obstetrician. They send to us for specialist imaging and counseling, and we further send it to the prognostication to the pediatric cardiologist. But every time the patient comes back from the imaging specialist to the obstetrician, the patient asks this question, Madam, what do you think? Madam, आपके मन में क्या है? आपको क्या लगता है? Again, when you send the patient to the fetal medicine specialist, whatever the counseling we do, then the patient goes again to you and asks, Madam, उन्होंने तो ऐसा बता दिया, अब आपको क्या लगता है? What do you think? So the gynecologists have a clear concept of fetal heart disease, how we gonna prognosticate, how we counsel them, and what are the measures they will take further when it is diagnosed. So this is the significance of this talk, and I am truly grateful to Dr. Sadhajan ma'am to put this talk into Delhi Gynae Forum. So the first thing the obstetrician know that there is some poor prognostication factor. So this factor is the presence of cardiac failure, associated aneuploidy and other genetic diseases, associated extracardiac malformation, or combination of all of these. So how to judge from the report that there is a presence of cardiac failure? So if your imaging specialist write that there is a mild pericardial effusion. So mild pericardial effusion is the first sign that heart is going to be failed. It is going to go in the failure because heart is not working properly. Later on, you will see the fluid in other parts of the cavity, like the pleural effusion or ascites. So, if any of the medical heart malformation report, if there is a mention of minimal ascites or mild effusion or minimal pericardial effusion, you must know that these are the poor prognostic factor, and the chances of survival of the baby is not much. Secondly, you should look for the baby as a whole. I always tell this fact, because there are associated extracardiac abnormalities, and this is the reason that the fetal echocardiography should be done as a diagnosis by the fetal medicine specialist, because they are going to see the baby as a whole, and it is prognosticated by the pediatric cardiologist, because they will prognosticate that very disease. So risk is increased even in the presence of normal karyotype. So karyotype might be normal, but the risk of extracardiac abnormality is always high. This risk is dependent upon the specific fetal malformations, and whenever you detect abnormality in more than one organ system, you should always have in your mind that there must be some concomitant chromosomal abnormality. And if you are seeing, of course, non-immune hydrop, we just discussed, it is frequently associated with the congenital heart disease. So the central nervous system abnormality is most one. is 71%, followed by the genitourinary system, a skeletal system, respiratory system, gastrointestinal system, and craniofacial. So these are the major extracardiac abnormalities. Those are associated with the cardiac activity, and we should keep this back in the mind. Thus, whenever we are seeing the heart defect, congenital heart defect, if we are seeing a report of the congenital heart defect, we should go to the, your detailed anomaly scan also, and you will see that whether there is any soft marker for the chromosomal defects or not. Because chromosomal defects in fetuses are associated with 30 to 40%, and in infant with 5 to 15%. So most of these fetuses die in utero. That is why the incidence is less in the infants than that of the fetuses. And there is a familial recurrence also, though this is less, because in 70% of the cases they are isolated. So it is worth asking the patient कि तुम्हारे घर में किसी और को भी congenital heart defect diagnosed हुआ है या नहीं. So this is always a part of your history taking. Plus, there are some ultrasound findings also, like just Dr. Deepika Deka ma'am has told us criss-cross sign. So what are these ultrasound findings that you should see? I'm not going to teach you whole of the fetal echocardiography. I'm just going to give you tips depending upon my long experience of the fetal echocardiography. I'm doing it since 2009, and I'm doing almost 200 patients in a month. So I have derived that few of the ultrasound findings when present, they have poor prognostic markers, and when few are the present, they have good prognostic markers. So these are just the tips and tricks. So there are some good prognostic markers, and there are some poor prognostic markers. So the good prognostic markers are the normal ventricular size and function. The size of the outflow tract. Outflow tract means left ventricular outflow tract and right ventricular outflow tract. A small pulmonary artery, and when it is not duct dependent. I will discuss each of these points. The prognostic factors, either ventricle is hypoplastic or poor functioning, either outflow is stenotic or atretic, that is small, or a small aorta in comparison to a small pulmonary artery, and whether this is duct dependent lesions. So when you are seeing this kind of pictures, like madam has just told you will see the picture and you will see that whether heart is good or bad. So if you are seeing this kind of picture where all the four ventricles are clearly seen, all the four chambers are clearly seen, the right ventricle or left ventricle, right atrium and left atrium, and you are seeing that their atrioventricular valve is also working very fine. You're seeing the flow, there is no regurg as such, so you know that there is a normal ventricular size and function. But if either of the ventricle is hypoplastic or poor function, then the surgery will be difficult because we cannot create the ventricles. Ventricles is a major factor in the heart. So we have to do multiple corrective surgery to make a artificial ventricle. So that's why wherever the ventricle problem is there, the chambers problem is there is always a poor prognostic factor. So if you see any of the report and if you see that there is a problem lying with the ventricle, then you know that you are going to deal with a poor prognostic fetus. Similarly, we see for the size of the outflow tract, outflow tract and the left ventricular outflow tract. The reason being, if the size of this ventricular tract are good, then we can do the switch operation if needed. But if the size is bad, then we have to do the switch operation is difficult because we cannot do the corrective surgery for the outflow tract. We cannot make something narrower to make it for the full size. So wherever there is a normal size of the outflow tract, that is a good prognostic sign. And whenever there is a atretic or stenotic outflow tract, that is a poor prognostic sign. Similarly, if as a patient you have to choose between a small pulmonary artery and a small aorta, the choice of defect in small pulmonary artery or always way than that of the aorta. Why? Because if we do the correction of the pulmonary artery, then the corrective outflow tract is supplying just the lung. But if we are correcting aorta, then it has to supply whole of the body. The corrective outflow tract, the aorta has burden of supplying to whole of the body, so it has a poor prognostic factor. So any of the disease in which there is a small aorta is having a much poor prognostic factor than that of the small pulmonary artery. I think that you all are with me till now. Now, what is the duct dependent and what is the non-duct dependent? So any lesion that is critically obstructive lesion, like if your aorta is critically obstructive, severely obstructive, or your pulmonary artery is severely obstructive, so we cannot make the corrective surgery because the ductus is the only way to supply to the right side of the circulation. If I'm not clear, I'm again slowly describing it, because see, the only way through we have to give the circulation from right side to left side or left side to the right side is through the ductus, and this ductus is going to vanish after the birth. So if there is critical obstructive lesion, so when the ductus is going to vanish, is going to be out of the function, then at that time, if there is a critically obstructive lesion either on the right or the left side, then that will cause the problem. Similarly, if we have a CSG with parallel outflow tract, the switch sign is because both the outflow tracts should cross each other at 90 degrees. So they are switch sign. But if they are parallel track, so we cannot make the corrective surgery and we have to be dependent upon the ductus. So in that cases, we have to give the medication to keep the ductus open after the birth. So these are the four ultrasound findings that I have seen in my practice, and those have a good prognostic factors and poor prognostic factors. So let's apply these findings to the various diseases, plus the knowledge I have already given to you in the previous slides. So first, the ventricular septal defect. So whenever the ventricular septal defect we see, most of the people relax. जैसे कि चलो छोटा सा है, ये तो जब तक 5 मिलीमीटर का नहीं रहता है तब तक कोई बोदर नहीं करना है, ये तो बर्थ के बाद खुद का खुद. No, this is not. We have to go for our basic principle. We have to rule out the extra cardiac defect. So in this patient who was sent to me for the referral for the very tiny ventricular septal defect, I saw that whole of the heart is very much normal. But then as my habit, I started seeing whole of the baby. So the referral was just for the fetal echocardiography, and I found that there was a bilateral pylectasis and there was a tiny innocuous intracardiac echogenic focus. So I convinced the patient and the obstetrician for the amniocentesis, and the result was trisomy 20. So these are the very subtle findings, but we should not take them lightly. We should always search for other findings in the baby. We always have to see the baby as a whole. Second is left heart syndrome. So what happens in left heart in hypoplastic left heart syndrome? The whole of the left heart is small. That is left atrium, left ventricle, outflow tract, aorta, and atrial mitral valve. So here you are seeing only one ventricle and opening because it is the right atrium and right ventricle. Left atrium and left ventricle are too small to be seen here. Now we have aid of the technology. When we counsel the patient, we call them in the ultrasound room, we show them our 3D, 4D pictures, we make them understand what the problem is. Like if you see in these rendering pictures and the 4D stick picture, then you can clearly see that the flow is going only on one side, it is divided on the other side, and there is a ventricular septal defect across the left and right ventricles. Similarly, if you see this rendered image, anyone can see that the right ventricle size is much more than that of the left ventricle, and left ventricle is very poor functioning, and there is an athletic valve also. If you compare the two valve opening, you can clearly see that there is a very good opening of the tricuspid valve, whereas there is a very poor opening of the mitral valve. So we make them understand what the problem lies in the baby. And then we come to our formula of the rule of the thumb. So here what we are seeing. We are seeing that ventricle is hypoplastic or poor functioning. Outflow tract is also stenotic and atretic. And the outflow tract, unfortunately, is our small aorta. So the prognosis will be poor. So plus we also need to see for the extra cardiac defect as well as the aneuploidy chromosomal defect. So they are associated sometimes with the Turner syndrome, trisomy 13 or 18, and there might be chances of extra cardiac abnormality. So generally these patients go for the termination of the pregnancy depending upon these findings. Tricuspid dysplasia is something that is very interesting case in which you see that there is an abnormal tricuspid valve with a normal insertion of the leaflet. If you see in this picture that's from the book, so you're seeing the tricuspid valve is abnormal with normal insertion leaflet, and there is a thickened tricuspid valve having improper closure. So if you see this big reflux, so this regurgitation, this one is due to the thickened tricuspid valve having improper closure. So we have enlarged right atrium, but we have normal right ventricle. Plus we have near or normal near or very small RVOT, but most of the cases they are normal. So how to prognosticate this case? So if we go for the rule of thumb, so we are seeing that we have a small pulmonary artery rather than aorta, and most of the time our outflow tract is also normal. It is hardly stenotic in few of the cases. Ventricle having normal size. So, and this is a non-duct dependent lesion also. So the prognosis is good. So in these cases also associated chromosomal and non-chromosomal abnormalities are rare. Outcome is usually good except in its severe and rare form when we have a critically obstructive pulmonary artery. Similarly, in tetralogy of Fallot, we have first ventricular septal defect and we have overriding of the aorta. What is that? That the aorta generally arises from the left ventricle, but here the flow is coming from the right ventricle also. So what happens? Aorta will be dilated and MPA, main pulmonary artery, right ventricular artery, and the pulmonary artery will be narrowed. So the cause of this disease. Similarly, we can again put the 3D, 4D and rendering to make the patient understand. If we are seeing in this 3 vessel view, we have very small pulmonary artery, and we have dilated dextrorotation aorta. So how to go with our rule of thumb? So if we are seeing here, so we have normal ventricular size and function, and the outflow tract that is small is the small pulmonary artery rather than a small aorta. It becomes duct dependent only when the pulmonary artery is critically narrowed. So how to prognosticate? So they are associated with 21, 18 and 13, 22 to 11 deletion syndrome. But what we need to see, we will do the follow-up for the pulmonary artery. If pulmonary artery is till the term, then the chances of having good outcome is much more. So generally, these may be, if we have ruled out associated chromosomal anomalies and syndrome, then and pulmonary artery size remains good till the end, then the outcome in these fetuses are always good. Similarly, we have in double outlet right ventricle, both the outflow tract is arising from the right ventricle. So that is why this is called double outlet right ventricle. So if you are seeing here, you can clearly say that both the outflow tract are coming from the right ventricle. Here also it has been well shown that it is coming from the from the right ventricles. Here we are seeing that there is very good flow in the right and left ventricle, but the right ventricle is showing both the outflow tracts. So how to go with our rule of thumb? So here we are seeing that the ventricle is normal, and there is a normal and it is a duct dependent reason. How? So if, but we have to see for the other things also, like the extracardiac anomalies and the chromosomal abnormalities. So extracardiac abnormalities are very common in these fetuses. They are associated with chromosomal abnormality like trisomy 18, 13 and 22q11 deletions, and association of anomalies in atrioventricular valve and conotruncal anomalies increases the risk for the chromosomal abnormality as well as the 22q11 deletions respectively. And association of DORV with isomerism practically excludes the presence of chromosomal abnormality. So to make the life simpler for you people, so we have applied our rule of the thumb, and we are seeing that all are good prognostic factors. But unfortunately, these fetuses are associated with extracardiac and chromosomal abnormalities. So the prognosis will be poor. So I have particularly kept this case to understand that it is not the ultrasound finding that is important. We have to always look for the chromosomal abnormalities as well as the extracardiac abnormalities. So now how we actually prognosticate it. So after taking all this knowledge from the ultrasound, from the history, from the amniocentesis, from the markers, so we follow Allen Hugin grading system that actually involves all of my fundas, my tip and tricks that I have already discussed. So it divides the whole of the CSD into group A and group B, where group A is having cardiac into a critical outcome to be solved. So say that whenever you have a CSD with associated extracardiac defect, go for a TOP. That's it. Group B is having none or minor extracardiac defect, and it is further subgrouped into B1, B2, and B3. B1 is CSD with good prognosis, was easily treated with no effect on the child in the long term, and after counseling plan, close follow-up for this group. So this involved a VSD and tricuspid regurgitation with normal karyotype that we have already discussed. And group B is having intermediate prognosis that can be repaired surgically with low mortality. However, long-term survival is to be affected. So we need to prognosticate and counsel them in detail and let the patient take their own decision. And this involves our TOF, EGA, TAPBC, abstain, DORV, coaptation, and ABSG. In our setup, most of patients in group B also go for TOP itself. So B3 is having CST with poor prognosis, cardiac lesion with a high mortality following surgery, and it requires repeated surgery during childhood and likely to have a cardiac compromise as a young adult. So this involves all of those having poor ventricle size and poor ventricular function. So and when they are complex also, that is associated with other cardiac or extra cardiac defects. Now the question that patient asks us most frequently: what are the chances of having my second child will be normal? So the data says that recurrence rate of CSD is 3.98%, 3.5% in case of one previously child, 4.5% with two children having CSD, 5.2% with mother alone affected, and 7.5% with father alone affected. So you can quote this data to these patients always. And when to deliver? The question is asked to me very, very frequently. So that is I have in my talk here. So the rule is always at term, because preterm delivery negates the advantage of prenatal diagnosis. We have done the prenatal diagnosis only when that we should prepare at the term to deal with this baby. If we will take the baby out, then the support mechanism in the fetuses is not developed, and the chances of survival will be poor. So we have multiple studies to know for the impact of the preterm delivery. So this was the data published from Evelina and Great Ormond, and they have concluded that fetuses delivered before 35 weeks, 30% died soon after the cardiac procedure. So even if you are doing the corrective surgery also, they are not mature enough to handle and withstand this kind of surgery. So the overall mortality is 70%. Another latest work, this one published in the Pediatric Cardiology Journal, and here also the mortality rate is also 70 or 74% also. So we should avoid delivering this baby prenatally. So when to so this data, where if we see that the odd ratio of the mortality, this mortality is going down and is the least between 39 to 40 weeks. So in 39 to 40 weeks, we have less mortality, less morbidity, and less complication. So this should be the ideal time for the delivery of this fetuses in a specialized setup. But there are indications of preterm birth also. We should ask two questions to ourselves. First, if the postnatal circulation is good enough for the fetus to survive the surgery, or is there an intervention postnatally that could save the life? So I have found this one condition, the refractory arterial flutter, and it is refractory. So you are not going to do anything antenatally. So we have to do the DC cardioversion after birth postnatally. So again, between mode of delivery, planned vaginal delivery, and the cesarean section. We will again debate the question of fetal echocardiography, but the question we should ask to ourselves: who our country has a robust cardiac screening? Our soul will tell no. Day in, day out, we are seeing that we don't have robust cardiac screening. So whatever we tell on the high platform, the fact remains we need either robust cardiac screening. Until we don't have robust cardiac screening, fetal echocardiography is the only answer. So my take-home message will be: look fetus as a whole, look for associated chromosomal syndromes, look for associated extracardiac defect, that is non-chromosomal syndrome. Go for the rule of thumb. In most of the cases, this holds true, and you will able to give the answer to your patients as a whole before sending to the expert. Thank you so much for all your patients here.
Thank you so much, Dr. Gopal. It was very informative, very enlightening for all obstetricians. Now I would request all the experts to give their comments. Dr. Deepika, ma'am. Ma'am, unmute, please. Ma'am, please unmute.
So what I'm saying is that obstetricians should know very well, of course, what are the findings that we may see. But basically, what obstetricians should know is when to refer. When to refer. So actually, Dr. Gopal, if you could tell us, the indications. Like supposing the mother had personal disease, or the mother is taking medicines, like hydantoin, has taken other things which are at risk of having a baby with a congenital heart defect. Those are the cases that we need to refer to them. Because if you send each and every patient, it will be a very big load. And then the normal ultrasonology, when we do at 18 weeks, and if that ultrasonologist just looks at the femur length, abdominal circumference, and everything else. At the same time, the 4-chamber view and the they say outflow tracks, that is enough actually. So we don't have to send every patient for a echo. So I want the obstetrician should know that much at least. Thank you.
I have to say something here. See, actually, one paper is published lately, Fetal Echocardiography so far, and this paper was published in 2020. It is on the net and has free access. So if you go, that has combined with large data, and what they say that the cardiac defect is more common in low risk population than in the high risk population. First. Second is, if we see the cardiac screening as a whole, not in I'm talking pan India. So if you see that beside 4-chamber view, if 4-chamber view is also not the counting of the chamber. If you go to the ISWAP guideline, then there is a large checklist. There is a huge checklist of that include the 4-chamber view as well. So my point is that if we see that there is a robust screening, the person has seen the 4-chamber view, left outflow tract view, right outflow tract view, previous tracheal view, and you know that correctly it might make sense. But then you see that the incidence of down 1:1,000 around. And incidence of CSD is approx 1:900. So we have to do something for the CSD, and most of the people who are doing level 2 is having a package in which you can just add 1,000 rupees and you are getting a fetal echocardiography. So I think that if patient can afford, and before my talk we were also discussing that this is a time to save our skin. So it is not a bad idea to offer this patient a ma'am.
That will be a very big load for the cardiologists, for the ultrasonologists.
नहीं मैम, एक्चुअली सी जब हम कर रहे हैं 20 weeks scan ना, mid trimester annual scan, then we just go to further 3 to 4 steps. So but if you are sending them separately, then that is a big load. Secondly,
okay. So we should write the detailed genetic scan plus echo.
Yeah. That's what I'm trying to make a consensus here. You see, actually, tomorrow if the cardiac lesion will be missed, the judge actually, मैडम आपने fetal echo suggest नहीं किया, और पेशेंट आगे कहता है कि मैडम आप तो कर देते, हम तो उसको करवा लेते. So the point is that we can offer if we find that your cardiac screen is not robust.
Dr. Jyoti?
Thank you, Dr. Gopal. Very informative lecture. You have made the very difficult topic very simple. अब तो सिर्फ करना ही बाकी रह गया, बाकी सब तो आपने बहुत अच्छे से बता दिया. I would just like to know, keeping in mind what Dr. Deepika Deka was saying, for the low risk patients, not for the high risk patients, keeping in mind the latest MTP Act, what will be the right time to send for the fetal echo as a routine for every patient?
Ma'am, see, I urge all of you to combine with our 19 weeks scan only, so that patient should not have further financial load. And if needed, we can call them at 22
or 23 weeks.
22, 24 weeks if needed.
And
Dr. Gopal, how confident are you at the 12 weeks scan to look at the heart properly. 12 weeks scan.
12 weeks, ma'am. I can see the 4 chambers. I can see the outflow tracts very well.
And sir, I would also like to know, many times when we send the patient for echo, we get a report saying everything else is normal except for a small echogenic cardiac shadow. So how do we counsel these patients? What all do we need to counsel and how to go about it?
In fact,
most of the time we get this report.
Highlighted in every case.
So if there is an isolated echogenic focus and if your dual marker is normal and there is no other soft marker, you should tell the patient that this is present in 50% of normal Asian population. You need not to.
Yeah, but you must make sure that the biochemical markers are okay, that the patient is young, and there are no other soft markers.
There are only 2 things. First is there should not be any other soft marker, and third is if you modify your dual marker chemical marker risk, then the modified a priori risk should be within the
normal range.
Normal range, no risk.
So we need just to reassure the patient about it.
Yes.
It is present in 50% of the Asian population normally.
But Dr. Gopal, you will advise them to do a fetal echo, na?
Ma'am, definitely. Because Sharda ma'am will tell here, we have different experiences and we all have learned that it is better to be safe than the sorry.
At least look at whether the patient get it or not.
What I find is, one message, clear messages. I think I will like to stand corrected by Dr. Deepika Deka. Whatever my gathering is, that whether you do level 2 ultrasound, whether you combine with echo also, 50% of the congenital heart disease you will not pick up. So this particular part you must be told to them, but the judge, once you are caught up in a litigation, the judge will definitely ask you, डॉक्टर साहब आपको किसने नहीं कहा था कि आप इसको इको मत कराओ? पेशेंट भी यही पूछेगा, उसकी वाइफ भी यही पूछेगी और जज भी हमसे यही पूछेगा. तो एक बार डॉक्टर खुराना ने कह दिया तो एक्चुअली मैं कई बार कहती हूँ कि everything is all right. Dr. Jyoti has said everything is all right. Why she has suggested you echo? Because in spite of echo is done, 50% cases it will be missed out. It's only for that reason she wants to be proactive that she's not caught in litigation and she sends them for echocardiography. So this is what I think there is more load about it. But I think, working in metros, you got to be careful.
I write for every patient.
Our indications are changing.
And I would also like to know, sir, what about dextrocardia as an isolated problem and maybe associated with complete situs inversus? How do we counsel these patients?
Doctor, we will ask Dr. Jyoti Malik in the meantime, what is her views about echo?
Ma'am, good evening and thank you so much for giving me this opportunity to listen to such a wonderful talk, number one. And secondly, actually, since in the era of litigation, in fact, few days back only, we had a patient, had no problem. All her markers, double marker screen were negative, and the baby turned out to be having a congenital heart disease. And from that time onwards, I've started writing fetal echo for each and everybody. They get it done or they don't get it done is another issue. And the secondly, I prefer doing a level 2 at around 21-22 weeks where we can see the heart better at that time. And we can combine both of the things. As Dr. Gopal said, you can do it in the same go. But the problem is, not many radiologists can do fetal echo that comfortably.
That's right.
That is the issue.
More time consuming.
Also, Dr. Malik, it will, if you do all the level 2s at 20, see, it's not very easy to get a termination done between 20 to 24 as yet. I think we still better stick to the 18-19 weeks.
No, Dr. Deepika Deka. Now it has been gazetted, and 2-3 times we've had a meeting.
Yeah, but madam, in our Cloud9 only, we've had problems getting actually done. Have to go and meet the CMO. Have to go and get a judge.
No, doctor, but not between 20 to 24 weeks. Till 24 weeks, there is absolute. one person, two people have to sign. In any way, we were two people were signing about it. And you have to give the report and you can get it terminated. There is no problem. The problem is late pickup. If you pick up late, still the boards have been not founded, and you can find difficulty at this particular time. Now Asmita has taken over and she's one of the in charge, for constructing the board. I think she'll be able. But the message which I want to give is that as in Mongol babies, majority of the cases occur in low risk, and the same is true with cardiac heart defects also. That majority of your cases will be in the low risk category. High risk, in any way you will get it done. But in low risk category, it is there. Unless you make a universal phenomenon, things will not be there. But I want to say that all gynecologists must have the information with them. फिर वो क्या करते हैं, वो उनकी problem है.
Correct.
Madam, I just want to ask one thing.
Let me just ask you, Dr. Deka. Dr. Deka, Dr. Jyoti, luckily has one case against her in the court. Now, this lady came with 3 abortions earlier. She had a level 2 ultrasound by one of the relative, which is very renowned person. He got the level 2 ultrasound done from there. Okay. We were happy that she got it done. Then Dr. Jyoti said, there is something mujhe heart mein problem lag rahi hai. Heart mein problem lag rahi hai. So at 28, very categorically, it is long time back, categorically written that she should have an echo. She went to the same renowned person and he says, echo is okay. And doctor, the child is born with all problems. And the litigation is on Dr. Sharda Jain and Dr. Jyoti. मेरे को तो एक word ultrasound का नहीं आता डॉक्टर साहब, इको तो बिल्कुल ही नहीं आता. But this is what it is. We have to be proactive. I have quoted,
I guess our times are changing.
I've quoted, the NICE guidelines, where they've written down 11 malformations can be missed out. Anencephaly can be missed out in 2% of cases. Heart disease can be missed out in 50% of cases. Kidney disease can be picked up in only 70% of cases. 30% of cases you will not miss. वो सब चीज लगाने के बाद भी मैडम लेवल 2 अल्ट्रासाउंड के साथ वो सारी कागज लगाती है कि ये malformation पिकअप नहीं होगी. फिर भी लिटिगेशन है डॉक्टर. And that is why we are requesting Dr. Khirana that please हमारी हिंदुस्तान की भी कोई गाइडलाइंस होनी चाहिए भाई ये malformations नहीं पिकअप होंगे. And I was promised by 21st of March they will give us the gynecologists will be gifted in this particular country. But I think it is still in the process, and I will want Dr. Gopal to make a commitment for the same. So on this, what do you have to say? Doctor, government sector की कोई बात अलग है, but private sector.
Yes, I guess so. Because now also I've seen that our colleagues. They are advising NIPT to everybody. करें ना करें अलग बात है.
डॉक्टर NIPT तो मैं कहूँगी अभी नहीं करेंगे. वो बहुत जल्दी हो गया. अगर डुअल टेस्ट इतना बढ़िया टेस्ट है, अगर वो टेस्ट अगर आपका
लेकिन फिर भी मैडम that 20-30% is still left to chance. I'm saying that the trend is coming in.
So, anybody wants to make any comment? Dr. Jyoti Malik and Dr. Agarwal, you want to make any comment? And I want to ask anybody.
Yes, I want to ask a question. Till what level of gestation can we advise fetal echo? Like some patients come late to us in the late 2nd trimester or something 3rd trimester. Till what level can we advise? Write on the paper that, okay, you haven't had an echo done, so get it done.
Whenever you suspect, you should advise it. One thing is very clear that now for malformation, which is not going to, if the child is not going to be viable afterwards, you should have the investigation done. He is very clearly categorized B1, B2, B3. You can prognosticate. He can prognosticate, you can prognosticate, और आप उनको बताएंगे कि आपने क्या करना है. एक इसने और टिप दी है मुझको कि डिलीवरी जो है कभी भी टर्म से पहले नहीं करनी, because those babies do not have a support system developed, so we should have only term delivery in such patients. और अगर आप उसको उस सेंटर में भेज सकते हो जहाँ पर कार्डियक सर्जरी की फैसिलिटीज अवेलेबल है, इमीडिएटली तो होगी नहीं, फिर भी आप वहाँ उन सेंटर में करा सकते हो. But otherwise, I think, they can deliver the way you like. But I think, a center should be at least level 2 or a level 3 center.
मैम एक चीज और ऐड करना चाहूंगी. मैम, not only fetal echo, maternal echo in all women, pregnant women at 35 and above. We should do maternal echo because so many cases. नहीं, और we should. क्या आप क्या बोल रही हैं?
डॉक्टर साहब ऐसा है, फिर तो कोई एंड ही नहीं होगा डॉक्टर साहब.
कितने केसेस मैटरनल मतलब डेथ ऑन टेबल और बाद में ये पोस्टपार्टम कॉम्प्लिकेशंस, पेरीपार्टम कार्डियोमायोपैथी 35 एंड अबव और एटलीस्ट आईवीएफ केसेस व्हाटएवर सम. मतलब अभी मैंने तो 35 एंड अबव डिक्टम बनाया मैटरनली को. आई डोंट नो आई एम रॉन्ग और व्हाट, बट
डॉक्टर मेरे एक नेबर है, नर्सिंग होम है, उनके हस्बैंड एनेस्थेटिस्ट है. वो हर मैटरनिटी पेशेंट में ईसीजी जरूर कराते हैं. तो मैंने पूछा कि मैडम ये ईसीजी क्यों कराते हो? तो उसने कहा मेरे हस्बैंड ने बोला है कि भैया पेशेंट टेबल पे आने से पहले ईसीजी होना बहुत जरूरी है. तो आप इको की बात करें. डॉक्टर गांधी, यू वांट टू से समथिंग? डॉक्टर कुमार गांधी.
Yes, ma'am. I also would recommend strongly for above 35 to get an echo done. Ma'am, what happens when there is a legal issue? Everyone says deficiency in services. So that part should be taken care. We should advise them. Whether they get it done, it's up to the discretion of a patient. But my strong suggestion would be that yes, above 35 or any kind of anyone in the family having a cardiac problem should be advised definitely to undergo a fetal, the maternal echo as well. And one physician opinion before the delivery should be taken for any kind of a reason. कभी बोल देता घबराहट हो रही है, भैया एक बार फिजिशियन को मिल ले. So that deficiency in services is not the kind of a problem for us. We have given our services, we have given them a physician opinion, we have given them the opinion or this thing regarding the echo as well. But I think it should be about 35, but I strongly suggest that the maternal echo should also be included.
डॉक्टर मलिक, आपको सेकंड करने के लिए लोग आ गए. I did not think.
Thank you so much. Ma'am, but
I did
we
not
have
think,
to be
yes,
careful.
All patient of surgery, elective gynae surgery. ये चीज मैंने सीखी चंडीगढ़ से कि आपने एनेस्थेटिस्ट को जरूर दिखाना है, आपने फिजिशियन को जरूर दिखाना है. प्री एनेस्थेटिक चेकअप एंड प्री मेडिसिन चेकअप. बट ये मैंने कभी नहीं सोचा. यस, नहीं, जब भी प्रॉब्लम होती है मैं बोलती हूँ फिजिशियन को दिखाओ, पर हर एक को फिर इनका हाथ लगाना है ये मुझे नहीं मालूम था. बट आई थिंक
मैम एक बात कहना चाहती हूँ, हमारे कार्डियोलॉजिस्ट हैं वो बोलते हैं कि नहीं ईसीजी ज्यादा इम्पोर्टेंट है. आई मीन इको कराओ या ना कराओ मैटरनल, बट ईसीजी इज मस्ट. वो टेबल पे आने से पहले ईसीजी कराओ. 35 है 30 है नो प्रॉब्लम.
नहीं डॉक्टर, मेरे जो नेबर्स हैं डॉक्टर मीरा संगानी के, वो ईसीजी कराते. मैंने कहा क्यों कराते? उसने कहा मेरे हस्बैंड ने बोला है भैया टेबल पे आने से पहले ईसीजी जरूर होना चाहिए.
But madam, we do ECG now for all gynae cases.
नहीं, गायनी नहीं बात हो रही डॉक्टर साहब, ये तो मैटरनिटी हो रही है डॉक्टर साहब.
हाँ, मतलब gynae cases में even if it is a young, we do.
डॉक्टर साहब एक बात बिल्कुल क्लियर है. The message which I want to send, there are very senior people here, Dr. Deka and myself. I will definitely say ECG is well taken. 35 weeks. Whether you want to done echo, अभी मैं तैयार नहीं हूँ उसके लिए. ठीक है,
हाँ echo थोड़ा सा
तैयार नहीं हूँ. यस, फिजिशियन कंसल्टेशन के लिए जब भी कभी कुछ प्रॉब्लम हो जाए एक बार सीनियर फिजिशियन को दिखा देना जरूरी चाहिए. And I repeat again कि all malformations are more in a low risk cases. So it is for you to take whether echocardiography has to be done or not, and you sort it out, because one person I know, one of the very senior ultrasound, he always write down echo in the basic और हाईलाइट करके लिखेंगे और बहुत छोटे छोटे उसमें लिखा होगा it is non-significant, which Dr. Gopal has said. पर वो वाली जो इकोजेनिक फोकस है उसको बड़ा बोर्ड हाईलाइट करेंगे. इसका मतलब ये इस पेशेंट को पता होना चाहिए कि डॉक्टर जैन के पास जाके उनका दिमाग खाओ. Anybody wants to make any comment? Dr. Kumar Gandhi.
Wonderful interaction, though I could join little late. I was busy in a meeting, but wonderful interaction we had. And I always suggest to, have liberal opinion regarding, taking second opinions, taking physician opinion, getting echo. ECG also is a very good suggestion, even for, I feel, every patient. That's a very good suggestion, a cost-effective investigating tool. So yes, definitely that should be incorporated. And that part should be removed as much as possible from our OPD of deficiency in services.
Correct.
We provide every service. Now it's up to the patient whether to accept that or not.
I will say, Dr. Jyoti, you want to wind up this discussion, so we'll take self-help group. I think it has been a wonderful, Dr. Krishna Gopal. Always, whenever you present, everything is so crystal clear that the message is very loud and clear as far your presentation is concerned. There is nothing left. You take it or you reject it. It is up to you. But the facts are here in front of you. Now, I think it has been absolutely great, Dr. Gopal. Now, coming to the very second, thank you, Dr. Deepika Deka, for your valuable comments. But yes, the times are changing for you and for me and for the gynecologists to make up their mind. They should not say that, they did not have the information. To the self-help groups. This is, whenever you are in a practice, I will say three things. Not a single day you can practice without indemnity insurance. Whether you get it done for 5 lakhs or whether you get it for 20 lakhs or whether you get it done for 1 crore, that you have to only shell out 2,000 rupees more. So I will suggest that all gynecologists should have an insurance for at least 1 crore of rupee. Secondly, everybody should be IMA member. Everybody should be IMA member. And everybody gynecologist should be Delhi Gynecologist Forum member as well. Why I am talking about this? I will give you an example. I'm seeing a patient in the OPD, and somehow they want all our patients want 100%. Nothing should happen to the baby. Nothing should happen to the mother. There should not be any stitch abscess. There should not be any UTI. There should not be anything. Now, इस केसेस के लिए कई बार जो उनके बच्चे हैं, उनके हस्बैंड तो फिर भी ठीक है, they are not so aggressive. उनके जो बच्चे हैं, उनके daughter, son-in-law, son, they are very, very aggressive. Now, उन केस के अंदर वो कई बार यंग ब्लड होता है, तो कई बार वो हमारे तो वहां पर बड़ा बड़ा लिखा भी हुआ है कि जी आपको पता होना चाहिए 2008 का दिल्ली का रूल है कि अगर डॉक्टर के ऊपर हाथ करोगे, उनके ऊपर तेज से बोलोगे, उनके स्टाफ पे तेज से बोलोगे, उनके ऊपर हाथ उठाओगे, बिल्डिंग का भी कोई नष्ट होगा, आपको जेल होगी. 3 साल की जेल है, बेलेबल भी नहीं है और आपको फाइन भी देना पड़ेगा. और जितना आपने यहाँ पे तोड़ फाड़ किया है योगी साहब के साथ, वो तो आपको उतना ही पैसा लेते, उन्होंने बोला डबल पैसा आपको भरना पड़ेगा. उनको नहीं दिखाई देता. तो क्या है, कई बार और स्पेशली कई बार डेथ हो जाए या बच्चा मर जाए या कुछ और प्रॉब्लम हो जाए तो वो और हंगामा क्रिएट करते हैं नर्सिंग होम. क्लिनिक में चाहे इतना नहीं होगा पर नर्सिंग क्लिनिक में भी होगा, पर नर्सिंग होम में भी जो रूल होगा ना, ऐसे केस के अंदर मेरा एक्सपीरियंस पिछले 32 साल से ईस्ट दिल्ली में प्रैक्टिस करने से एक चीज पता चली है, गायनेकोलॉजिस्ट तो कभी एनर्जेटिक नहीं हुई, पर 50% प्रॉब्लम उन्हीं के पास होती है. बच्चा भी वही मारती है, लेडी भी उनके अंडर मरता है और कोई भी और भी छोटी मोटी प्रॉब्लम उनके अंडर होती है. तो ये IMA वाले ही लोग आते हैं, वही 15-20 लोग आते हैं हर बार. अभी नहीं, 20 साल पहले भी वही आते थे, 10 साल पहले भी वही आते थे, 5 साल पहले भी वही आते थे. और अब की बार वी आर वेरी लकी दैट कुमार गांधी, he is a gynecologist, he is the president. So I think यही बढ़िया टाइम है मैं आपको गगन विहार की बात करती हूँ। गगन विहार में मीना हरसिंगानी ने 20-25 डॉक्टरों को रोल इन किया और हर आदमी कहता हम आएंगे डॉक्टर साहब, हम समय पे आएंगे, जब आपको प्रॉब्लम होगी हम समय पे आएंगे। ओके, समय पे अगर हमारे पास आ गया, हमारे गगन विहार बहुत बड़ी जगह भी नहीं है, हमारी कोई प्रॉब्लम होगी, पास के लोग चले गए, हर आदमी अपने यहाँ से डॉक्टर भी चला गया, नर्सेस को भी ले गए, अपने और लोगों को भी लेके चले गए, बट आईएमए के आना बहुत जरूरी है। तो डॉक्टर साहब आप ये मुझे बताइए कि कैसे हमें टैकल करना है। डॉक्टर क्षमा बच्चा, पहले आप बोलो कि आपका होमवर्क कितना तैयार हुआ है। डॉक्टर क्षमा बच्चा, अनम्यूट योरसेल्फ।
Yeah. Good evening, everyone. The way we have learned today regarding the echocardiograph of the baby, the same way we should take care of our echo and our heart also. I think when we have any problem, our heart beats more compared to the other. So that is most important thing. We have made self-help group according to the area wise along with the Dr. Kumar Gandhi. And we have made the in charge also. First now, at present, we have added only gynecologist. And Dr. Kumar, within a few days, 4 to 5 days, he will start adding the IMA people along with that. Then we'll have that groups, and it will be our East Delhi, most probably 10 to 15 groups we can make in East Delhi. What is the purpose? Purpose is like that. It's not just we make group and we keep quiet. It's not like that. If we are making the group, we all gynecologists are very energetic, so that gynecologist should use their energy in this part also to save our skin. That is very important. And one thing is there, whenever we have group, it's nothing like that. If we are just sitting silently in that group, whenever we have a problem, all should come forward and they should take care of your colleagues. And please, there should not be any something like that. If this colleague has not done this thing, this colleague has not done that, but we should tell and we can explain separately to that colleague that this thing should be added, not especially not in front of the patient. That is very important. And very good suggestion. I came to know today only that ECG should be done, but I am doing for all obstetric and gynae patient because once I missed heart disease of the patient. From that day only I started doing just ECG. I used to do regularly because that time I missed and I had a problem, but patient saved later on with my whole staff and everybody. That is very nice. We should do. And we should keep on telling all these things, how to save a patient. Madam is a very good teacher of ours and regularly she keep on having the CMEs. Now we should do small Zoom meeting area wise. And we can have small meetings and we can tell you how to save ourselves, how to make our documentation also, that part, very important part. So I think that is the main purpose. Dr. Shada Jan ma'am, we have made many groups and we have the in charge also. Within a week or 10 days, I'll sit with Dr. Kumar and other doctors in charge and we'll have a meeting in IMA and then we'll go further.
Dr. Kumar Gandhi has given 4th as the date and we should sit across. सारे लोग जाके अपने ग्रुप वाइज बताएंगे कि डॉक्टर साहब ये लोग हम लोग आ जाएंगे और ये आईएमए के लोग भी आने बहुत जरूरी है क्योंकि
IMA list also is more than 50% ready. We have those people, those who are ready for even in the night, odd hours also they are ready because every time females won't be able to move in the odd hour. So we've kept those people also, those who are ready. Because ma'am, what we have felt, it's the head count which matters the most. It's the head count. We should have 15-20 people, even if all are not medicos, even 2-3 of our local area people, like someone who's a corporator, who's someone who can be a helpful person, who's a social activist, RWA president. So those type of people also can be of a help because it's a head count at the end of the day. If we have 15-20 people in front of a mob, they are little more quiet compared to if we are 2 or 3 found. This is the basic thing. So we are trying to work in a way that we have more and more number of people and to go and help everywhere. And one more suggestion we are trying to give everyone, that wherever we have gone and helped them, it is the moral duty of that person that any other place there is a kind of a problem, they should go and try outreach those people and help them out also.
Absolutely, absolutely. Doctor Sahab, today Anupma was supposed to come. She is coming on a live session which we are having on the 6th. She will definitely come down, and her friends are going to come down, because what they are doing workshops, for the last 3 years, it has been very effective. जिन लोगों को फायदा हुआ है वो बोलता है जी मेरे साथ इतनी मौत आ गई, इन्होंने हमें बचाया। फिर वो डॉक्टर दूसरा बंदा बोलता है कि ये मौत आ गई, इन्होंने हमें बचाया। तो उस तरह से डॉक्टर साहब वो उन्होंने इकट्ठे कर रखे वो लोग जिनको की फायदा हुआ और जिन लोगों ने ऑर्गेनाइज किया। शी विल टेल यू एग्जैक्टली कि अपने ही ग्रुप में आप देख लो कौन लोग फाइल देख लेंगे, कौन क्या कर लेंगे, कौन क्या कर लेंगे। ये चीजें हैं, हर एक काम डिवाइड होना चाहिए। जेंटलमैन वगैरह जो है वो कैसे किस तरह करेंगे, वो हमें अक्रॉस द टेबल बैठकर इसको डिस्कस करना पड़ेगा डॉक्टर साहब। क्योंकि ना डॉक्टर साहब ये वाली बात बिल्कुल क्लियर है। मैं आपको गायनेकोलॉजिस्ट की बात बता देती हूँ। वो ये बोल देते हैं कि डॉक्टर चंद्रलता कर लेंगी, डॉक्टर बत्रा कर लेंगी, डॉक्टर शारदा जैन कर लेंगी, मैं नहीं करूंगी, कोई बात नहीं। ये मैं नहीं करूंगी कोई बात नहीं, वही वाली बात है, बीरबल और अकबर वाली बात होनी चाहिए। अकबर ने कहा मुझे दूध का फुवारा चाहिए, तो सबको बोलो दूध डाले। हर एक आदमी ने सोचा कि मैं तो पानी डालूंगा, सब तो दूध डालेंगे ही। और देखा तो सुबह अर्ली मॉर्निंग में जब फुवारा चल रहा था वो क्रिस्टल क्लियर वाटर का फुवारा चल रहा था। तो ये वाली जो हमारी टेंडेंसी है कि दूसरा कर लेगा, दैट इज डेंजरस। एंड एक बात बिल्कुल क्लियर, अगर वो जिसको हमने मदद करी है वो दोबारा नहीं आया तो उसको तो डॉक्टर साहब बिल्कुल आउटकास्ट।
मैं एक बार कहना चाहती हूँ, मैंने ना अभी सबसे बात की अपने एरिया में, जैसे तो सर्जरी सेंटर वाले हैं डॉक्टर NK गुप्ता, डॉक्टर कुमार गांधी जानते हैं सर्जरी सेंटर, वो मुझे बता रहे थे चले गए हैं सर्जरी सेंटर छोड़ के देहरादून। तो वो मुझे कह रहे थे कि हम लोगों ने बहुत पहले, आज से 30 साल पहले बहुत ही जबरदस्त ग्रुप बनाया था, और अगर जरा भी किसी को प्रॉब्लम होती थी तो हम 25-30 लोग जाके वहां उसको बचा के लाते थे। डॉक्टर साहब को पता होगा। तो वो कह रहे थे कि ऐसे ही अगर आप स्ट्रॉन्ग होंगे, आप मतलब उनका कहना था कि यंगर जनरेशन की रिस्पॉन्सिबिलिटी मैं नहीं लेता, मैं नहीं कह सकता ये तुम्हारी यंगर जनरेशन जनरलता तुम्हारा साथ देगी कि नहीं, पर तुम लोग ही अगर इकट्ठे हो जाओ तो हो जाएगा। पर मेक इट अ वेरी स्ट्रॉन्ग दिस थिंग कि भाई हाँ करना है। तो उन्होंने कह रहे थे हमने बनाया था
हैं, तो इनको ये बताएंगे, थोड़ा अपना एक्सपीरियंस शेयर करेंगे। पर मैं एक छोटी सी बात बताना चाहती हूँ। इंदिरापुरम में जिसको बोलते हैं वेस्ट दिल्ली IMA, वेस्ट गाजियाबाद IMA, वहां पे काफी यंगस्टर लोग जो है एक साथ प्रैक्टिस में आए, यंगर लोग, और उनको एक के बाद प्रॉब्लम हुई। डॉक्टर साहब, दे आर वन ऑफ द वेरी स्ट्रॉन्गेस्ट पीपल। छोटी सी सोसाइटी है, सब लोग इकट्ठे हो जाते हैं, एक दूसरे को लोग सब जानते हैं एट पर्सनल लेवल। तो डॉक्टर कुमार गांधी, आपका पिछले साल एक्सपीरियंस सेक्रेटरी का क्या रहा, कितने लोगों को आपको जाना पड़ा?
Ma'am, we had gone to around 5 places, if I recollect, and that too, this is I am talking of odd hours. Odd hours में जो हम रात के 10 बजे से सुबह 4-5 बजे तक का कहते हैं, to 5 different places we had gone. Twice we had to go to the police station also. और उसमें क्या हो जाता है मैम कि we try to contact those people के वो उस एरिया में मैं हेल्प कर सके। तो फोन पे काफी सारे जैसे पुलिस वालों से भी बात हो जाती, फिर पुलिस फोर्स को भी वहां बुला लेते हैं। So it takes almost around 30 minutes to 40 minutes to gather people. वो 30-40 minutes जो crucial है कि जितने हैं available, मतलब 2-3 बार तो हम लोग स्कूटी पे निकल गए थे। We didn't wait for the car also. एरिया छोटा था, हमने सोचा कि स्कूटी पे निकल जाओ, PRO को लेके स्कूटी पे निकल गए। But it is again and again I'll say कि it's the head count. At the end of the day it's the head count. 15-20 लोग खड़े हैं। एक बार का मुझे इंसिडेंस याद है। He was a person of somewhat related to district magistrate. कह रहा है आप लोग तो इतने सारे इकट्ठे होकर मुझे 2 लोगों को धमका रहे हो। हमने कहा सर धमका नहीं रहे, आपको समझा रहे। We were 9 of us and there were 2 of them to try and disrupt the whole OPD. उनको सारा समझा के 2-3-4 घंटे लगा के सेटल कर दिया। The problem what we are facing, ma'am, is those who we help, they don't come back or they don't think also to help someone else in the crisis. This is the basic problem. जो हमारा मल्टीप्लिकेशन होना चाहिए वो उतना नहीं हो पाता है। एंथुजियाज्म हमारे जो 10-15 लोग हैं वो सोचते कि ये हमारी या तो रिक्वायरमेंट है या हमारी वो गरज है, जो भी समझ लेते हैं हम ही जाते हैं। दैट मल्टीप्लिकेशन और दैट जो होना चाहिए वो नहीं हो रहा है इसके अंदर।
डॉक्टर साहब, मैं इसका आंसर बताती हूँ। पुष्पांजलि मेडिकल सेंटर में मैंने बहुत दिन काम किया है। वहां पर एक चीज थी, अगर आप एक मरीज को बचाओगे जिसमें 15 15-20 लोग के कंसल्टेंट लोग लग के सबको बचा दिया, तो एक आपको डॉक्टर साहब लंच और डिनर पूरे स्टाफ को खिलाना पड़ेगा। ऐसी कुछ काम करना चाहिए डॉक्टर साहब।
गुड सजेशन, वेल एक्सेप्टेड, नो प्रॉब्लम मैम।
आई फाइंड कि अगर आपको किसी तरह से मारपीट से बचाया गया है तो उस केस के अंदर जो ना उनको किसी न किसी तरह से एक्नॉलेज करना पड़ेगा कि भाई आपको आप मदद के लिए आए डॉक्टर साहब।
सम्मान किया जाए मैम, some gratitude to be shown to them, definitely well accepted point
मैम। हमारे we people are doing a lot previously from 3-4 years, but जो गायनेकोलॉजिस्ट को जो एक्टिव होना है ना, वो एक्टिव होना बहुत जरूरी है मैम। अभी
डॉक्टर साहब आपका एक्सपीरियंस रहा है, आपने नीलम लेखी के टाइम में भी मदद करी, आपने डॉक्टर पूनम के टाइम में मदद करी, आपके टाइम पे कितने
डॉक्टर पूनम के टाइम पे भी हमारे पास 3-4 क्राइसिस थे, और एक बार तो डॉक्टर कुमार वगैरह भी थे उस समय, जो नाइट में जाके डॉक्टर दीपक वगैरह सब गए थे और नाइट में पूरे पुलिस स्टेशन पे जाके बैठे थे और बहुत ज्यादा हंगामा हुआ था। तो उसमें जो देखने को क्या आता है कि वी ओनली ऑफिस बियरर आर देयर मोस्ट ऑफ द टाइम, एंड और फिर दूसरा बंदा नहीं आता है, वो बड़ी प्रॉब्लम हो जाती है। वी कीप ऑन रिंगिंग देम, तो फोन ही नहीं उठाना बंद हो जाता है फिर उसके बाद।
नहीं डॉक्टर साहब, लोकल लोगों को अगर आप लोकल लोगों को नहीं 50% आपके लोकल लोग होने चाहिए, क्योंकि अगर डॉक्टर मेरे को प्रॉब्लम हुई तो मीरा हर सिंगानी 5 लोगों को लेके आ सकती है, बट और उसको प्रॉब्लम हुई तो हम लोग 5 लोग लेके जाते हैं। हेड्स तो हम ही लोगों ने बनाने, और एक सर मैं यहाँ पर बताना चाहती हूँ, आज से 13 साल पहले ये वाले शायद प्रॉब्लम्स रही होंगी, तो हमने मेडिकल लीगल फाउंडेशन बनाई थी, और उस टाइम आई वाज द प्रेसिडेंट ऑफ बनाया था। ये मैनुअल कर्टसी डॉक्टर गौरव अग्रवाल ने बनाया, उसको उसमें मॉडिफिकेशन थी डॉक्टर शारदा जैन की और डॉक्टर अरविंद की। वो मेरे पास सॉफ्ट कॉपी है डॉक्टर साहब, आई कैन गिव इट टू यू दैट सॉफ्ट कॉपी। एक बार डॉक्टर गौरव को कहिए कि उसमें दोबारा नजर डाल लें, और वो जितने भी 5-6 केसेस है जो हम लोगों को पता होना चाहिए वो सब हो उसमें, उसकी हमने उसको बाइंड करके डॉक्टर साहब, और आपने IMA में बुलाना है, यहाँ के लोकल DCP को बुलाना है, डॉक्टर मलिक की मदद लीजिए, और डॉक्टर मलिक की मदद से DCP, ACP और सारे SHO को वो कॉपी देनी चाहिए और फोटोग्राफ लगानी चाहिए डॉक्टर साहब।
यस, वेरी इंपॉर्टेंट।
फोटोग्राफ हमने अपनी एक दीवार में नीचे IMA में भी लगानी है कि भैया ये देख लो, ये फोटोग्राफ आपकी DCP की और ये ACP की और ये सब SHO की फोटोग्राफ है। उनको बुला के दिखाना कि हमने ये आपको मैनुअल दिया, और एक डॉक्टर साहब एक आपने पोस्टर बना लेना कि ये पोस्टर के साथ हमने दिया है, तो वहां पर एक चिपका देना भी बड़ा जरूरी है। पड़ेगी कि हमने आपके पुलिस स्टेशन पे ये पोस्टर लगवाने, जिससे कि आप उस टाइम मुकरो नहीं कीजिए, आपको पता ही नहीं इस रूल के बारे में।
अवेयरनेस इज नॉट देयर मैम, बहुत पुलिस स्टेशन में किसी के पास भी अवेयरनेस नहीं है।